Hi, everyone. We're just going to let a couple more people join, and then we'll get started. Okay, terrific. I just wanted to welcome everybody to our webinar on strategies to support brain health. As you know, this webinar features Dr. Amer Burhan. I'm Melissa Armstrong. I'm Director of Corporate Communications here at Amica, and it's been a true pleasure working with Dr. Burhan in preparation for today's webinar. I'm sure you know there's no shortage of information out there on brain health right now, and it can be difficult for people to know what to trust and where to focus. So our goal for today is simple. We want to cut through all that noise and bring you practical, research-informed insights that you can use in your everyday life, grounded in Dr. Burhan's clinical experience and his expertise as a researcher. I have a few small housekeeping notes before we get started. We're recording this webinar and we'll share it back with you afterwards in case there's something you'd like to revisit or if you'd like to share it with a loved one. And we'll field your questions at the end. So anytime during the webinar, feel free to type your questions into the questions section on your screen. And we will field questions at the end after Dr. Burhan speaks. And we've also prepared some articles on the topics that Dr. Burhan will discuss today. And you can access those articles anytime in the handouts section on your screen. And if you have any issues, your community relations directors have all of these articles available to share with you. Next, I'm going to introduce our introductory speaker for today. She is Ashley Sumler, Amica's Director of Quality of Life. Just a little bit about Ashley. She has been supporting quality of life for the seniors at Amica for 15 years now. Her background is in kinesiology and health promotion, and she's passionate about bringing to life meaningful experiences for our residents. These experiences inspire people to try new things and help our residents feel connected and fulfilled. Ashley has worked very closely with Amica's wellness team and Amica's Dementia Advisory Council to help shape and strengthen Amica's approach to memory care and to cognitive well-being overall. And Dr. Burhan has been a part of that work as well. So it's especially fitting to have both of them with us today. And now I'd like to pass things over to Ashley Sumler to get us started.
Thanks, Melissa. It's a pleasure to be here. Thank you all for joining. We know cognitive health is a really hot topic as we see our proportion of Canadian seniors rise and the prevalence of cognitive changes increasing across all of Canada. At Amica, our cognitive wellbeing program is really centered on people and relationships, and it's guided by 4 key pillars to ensure that we're meeting the evolving needs of people who are experiencing cognitive changes. We're really proud to have collaborated with Dr. Burhan to help strengthen our approach and stay aligned with evidence-based best practices. So firstly, we definitely work on prioritizing education with our team, our residents, and family members, helping people build confidence and expertise in supporting loved ones with cognitive change, and also provide ongoing guidance throughout each person's individualized journey. Through our discovery process and our family support program, we foster meaningful connections between residents, their loved ones, and our team, with the goal of really inspiring that feeling of possibility. So leaning into their capabilities, not limiting by diagnosis. Our engagement opportunities, including new signature programs being shared and rolled out this year, support proactive cognitive health and create moments of purpose, connection, and success for those people who live with dementia. And finally, our supportive environments featuring sensory elements, integrated health services really help residents feel safe, connected, and cared for through their entire journey with us. In staying up to date with the most recent research in the field of cognitive health, we're really excited to be testing 2 new technologies at a few of our Amica residences. Both technologies are coming to us from the Netherlands. The first is the Cradle, which is a music connection device that creates soundscapes through the power of touch. So it really creates connection that doesn't need words and just focuses on presence. The second is the Tovertafel, which is an overhead projection device that has games co-designed with people with dementia that helps create engagement, connection, and fun. And we're really seeing some amazing moments of accomplishment and joy with these technologies so far, and we're really excited to continue to share them across the portfolio. At Amica, we're really committed to staying at the forefront of cognitive health support and are excited that you are all going to have the opportunity to learn more about what's new in the field of cognitive health research and get some tips and tricks for what you can do to maintain your cognitive health at home through Dr. Burhan's talk today. So I have the privilege of introducing Dr. Burhan. Dr. Amer Burhan is the geriatric and brain intervention psychiatrist and endowed chair of applied mental health researcher at Ontario Shores Centre for Mental Health Sciences and an associate professor in psychiatry at the University of Toronto. He is also adjunct professor at Ontario Tech University in Oshawa, Ontario, and Western University in London, Ontario. He is internationally recognized for his work in cognitive and mental health research, and we are so excited that he's sharing his expertise with us today. So welcome, Dr. Burhan. We'll turn it over to you.
All right, thank you so much for the kind invitation to this event, but also the kind introduction. One bit of a starting point for me is to just describe the different areas that I work in and where do I do the work. So Ontario Shores, so as I mentioned, this is where I'm currently endowed research chair and practice geriatric psychiatry directly, so caring for people with dementia and help them and their loved ones. Also, I'm at University of Toronto. In fact, I just got the news that I'm officially promoted to a full professor. So that's a milestone for me to be able to continue the work that I'm doing. And one other area of practice that I particularly love because it complements all what I do is working with the Toronto Memory Program, where we are now in the really forefront of preventing dementias or detecting dementia as early as we could and do things such as removing the pathology from the illness. So I'll be sharing with you some of the highlights of the work that I do and how that helps all of us basically stay healthy and cognitively well and help each other out through that journey. The presentation is going to go over elements of cognitive wellness in aging, outlining the factors that can be modified to prevent dementia and cognitive change, appraise the relationship between mental health actually and cognitive health, because most people know that cognitive health is affected by mental health and mental well-being. And then the scope of interventions that are available both to prevent but also to treat and enhance the quality of life and function for people who are dealing with these illnesses. So most of us have seen these slides. This is actually from the Alzheimer International Organization, an advocacy group that really looked at the impact of dementia worldwide, and we still see a growth in the impact. So by 2050, we have 139 million people living with this illness worldwide. And of course, the illness is not just an illness. It does affect people's lives and livelihood and care system. It has tremendous impact when it comes to even cost of caring and time away from work for those who try to support their loved ones going through this journey. Now, to start with, dementia is something that you probably heard a lot. It's really not one thing, but Alzheimer's disease is the bulk of the cases that we call dementia. So, dementia is just an umbrella term to say that the person have lost some of the mentation or the ability to remember and talk and find their way around. But it's caused by different illnesses, and Alzheimer's disease is one of those neurodegenerative illnesses. So those illnesses that continue to unfortunately progress over time. And you know, a lot of the time these illnesses don't just come in one. I mean, they do happen together. So Alzheimer's disease and stroke can happen together, and people will have what we call mixed dementia. So our way of helping people is first to understand, why is this person struggling with cognitive function? Is it driven by something that we could treat, correct, and improve, or is it something that unfortunately going to progress? And how do we, reduce the rate of decline, or try to help people stay well as long as we could? The first case, really, or first patient that was described as Alzheimer is a young person, 51-year-old, who Augusta Dieter was basically Vienna, and Alzheimer, Alois Alzheimer was the clinician and the pathologist who actually examined this person, helped this person as much as they could, and when Augusta did pass away, Alzheimer was able to look at her brain, and he identified the illness, the cause of the illness. So we are now, believe it or not, over 100 and almost 120 years after that discovery, we finally have a drug approved to remove the amyloid plaques that you see on the right side here. So one thing to keep in mind, that this illness is not just memory, it does affect also psychological state. So a person could have delusions, hallucinations, agitation, depression, and therefore I feel that my job is to bring these two fields together to try to help people in both cognitive and mental well-being, mental health and well-being. One thing to also, again, I don't want to make this talk too technical, but it's important to know that the changes in amyloid, the one that Dr. Alzheimer have shown when it's already in the brain, really start much earlier. So basically, when you look at amyloid accumulating, so the first dashed line here in black, so a person could have amyloid going up, floating around in the brain many years before they develop other changes, and really they don't develop the symptoms. What you see here, MCI, dementia, that happens sometimes up to 20 years after amyloid start going out and up in the body. So we have an opportunity to make a difference, and that's what we've begun to do with the newly approved treatments that I'll share with you. This is what it looks like. So in the brain of a person with Alzheimer's disease, there's two things that we talk about. The amyloid plaques. This is a cluster of amyloid, big molecules of beta amyloid, tend to stick to the fibers, then start actually triggering inflammation, and eventually brain cells start losing connections and they start dying. And then inside the neurons, you see something called the tangles. So amyloid is something that happens first. So it could be floating around, it could be depositing in the brain, and then it triggers changes that result in unhealthy looking neurons and the tangles inside the brain. So those are the two pathologies that we do see. And of course, you'll see on top of the slide how eventually this results in progressive loss of brain volume and loss of neurons, which unfortunately result in the symptoms that we talked about. So right now, the field has really exploded in terms of being able to see amyloid in the brain. Well, we know that you don't want to wait for the person to go through this tough journey and die before you see the brain. We now have tools. So we have imaging tools. We can do something called PET scan. We can take fluid from the spine. But also, we now can look at the blood tests that can reflect Alzheimer's. So we have something called p-tau 217. So it's, the name doesn't matter, but it is a reflection of what happened in the brain. So what's amazing is that today, if I take a sample, a blood sample from people in their, let's say, 60s, and they have a positive, score, that's 10, 20 years before they can develop the illness. So in a way, you have 20 years of an opportunity to make a difference and prevent the illness, or at least push it as far as possible. Maybe, if you push it enough, it will not be the reason why the person would die. They would die from other causes that obviously I don't think at this point we have any promise for us to live together, live like forever. But at least being able to push it as far as possible. So our question about dementia is it only cognition or is it behavior? So from seeing people go through the journey, I know definitely from my career, from my personal life, and people that I know in my life that get affected by these illnesses, that it could present with something like depression as the first time in the people's 50s, 60s, mild behavioral changes, change in personality, disinhibition, and so on. But it get defined as an illness when you start talking about mild cognitive impairment. So there's a reliable change in remembering and finding words. And if that's consistent and detectable, then that's the beginning of what we now call Alzheimer's disease. And with this come also psychiatric symptoms. So basically agitation, psychosis sometimes, anxiety. So it's a long journey. Now, in terms of what, along this long journey, we can do a lot of things. So one is to prevent it to start with. So, primary prevention refers to the ability of stopping the disease from happening altogether. So this is when you say, what could I do in my, younger years, in my adult life, maybe my midlife, that would maybe, help me not even face an illness like this. So these are lifestyle changes, the risk factors that we could treat, including depression. But the other way of preventing things is to say, well, could I at least keep an eye on it and detect it as early as possible? And then if I detect any change in behavior or cognition, offer whatever treatment I have at that time. It doesn't have to be medical treatment. It could be the wonderful examples that was shared earlier by Ashley in terms of, cognitive activation. And I'll share with you some of those interventions. And of course, once you have the syndrome of mild cognitive impairment or dementia, then of course there's cognitive need, behavioral aspects, and functional aspects that we can work with. So we have been really working on all these aspects, from enhancing cognitive resiliency through multimodal interventions to help people have the best chance to stay well. We do treat depression, especially in late life, mid and late life, with using interventions, including advanced interventions with brain stimulation and cognitive enhancement through brain stimulation. We address behavioral issues through a model of non-pharmacological intervention plus medications when needed. And we have been working also on finding a way to predict these symptoms and make them more precise in the individual, so that we can be very specific about who needs what and when, right? Like, so you can't assume that everybody's going to need the same thing. Now, evidence-based medicine promises that only if something is proven to work beyond doubt in a statistically valid way should be applied. But, well, in reality, people are not the same. So there is a need to develop more precise and predictable and analytic tool. So we'll get now to what we know about prevention. So the Lancet Commission on Prevention of Dementia, this is a very elegant group that is led by Professor Livingston from the UK, United College London, who actually has a very good relationship with us. She just presented last month to the Canadian group. So this group were tasked to identify in the literature of any sort, what are some of the potentially modifiable, meaning things that you can change to prevent dementia, right? So they had at least 45% potentially modifiable cases of dementia. And you'll see early life, well, if you have somebody who grew up in a rich environment with good education, they already banked a lot of cognitive reserve, so that is protected to some extent. As you go to midlife, there's some illnesses and some factors that definitely plays a role, like hearing impairment. This is one of those things that most of us don't consider that seriously when it comes to cognitive impairment. It turns out to be very important to prevent. So if you have doubt that your hearing is not optimum, well, checking your hearing in midlife and wearing hearing aids is actually a good thing. And it's I know there's a stigma against having hearing aids because all of a sudden you feel like you're old. Well, I wear ones because my family developed hearing impairment in their 40s. So why would I not do what could prevent my cognitive decline? You can see cholesterol, high cholesterol being listed, especially the bad cholesterol. Depression is listed there. Of course, traumatic brain injury. So if you keep falling and injuring your brain, or you're in a competitive sport that results in that, that's important to think about and prevent. Physical inactivity. So those of us who have been super athletic and then middle age hits and all of a sudden they don't want to move anymore, well, that increases your risk. Diabetes, smoking, hypertension, obesity, excessive alcohol. So most people drink socially, but excessive alcohol definitely is something that we know can result in increased risk of dementia. In late life, you start seeing things such as social isolation, air pollution, which is a big problem for all of us, but it seems to actually predict dementia as well, and visual loss. So far, I've shared with you some of those general international level evidence. In Canada, though, we're lucky that we have a study called the Canadian longitudinal study on aging. So this is a study that follows people from age 45. And it's really, we're proud of this study because it produced so much knowledge about aging. So when my colleague Son and Manuel Montero Dasso from Western University have looked at what is the situation in Canada, like what is preventable, are we different or similar to the international community? Well, we are similar in many ways, but you can see that in midlife, hearing loss is 6.5%, traumatic brain injury maybe 4.4%. So it's actually gave us a little bit more of a view of what is closer to home. Depression, 4% of cases of dementia could be prevented if you treat depression, right? And one thing that showed up, which I've been asked about a lot, which what about sleep disturbances? So the first, the commission report did not list sleep, and people were upset about that, right? Because they said, well, I thought sleep has something to do with cleaning up the brain. So actually, the Canadian study that looked at that did indicate that sleep disturbance is a factor that could be prevented. And I'll share a slide about what is the latest evidence after the 2024 report being published. So, Amica have been kind to look into, bringing this knowledge to people who are they're served by Amica or thinking about, living there, or their loved ones as well. And we came up with these like big 5 factors that you can think about and modify, and that was published. And I think that's going to be one of the handouts you can access free of charge. So one is be physically active. We know that physical inactivity is a factor. So make walking daily a daily habit, 30 minutes a day. Make sure that you're walking brisk enough to make your breathing a little bit difficult, but not difficult enough not to be able to talk. It's a good exercise. If you have good shoes, make sure that you're safe and not walking in a place that could get you to fall or socialize during that time. Strength training, because we know that cardio that comes from walking is not maybe enough. So increasing your muscle mass through strength training is something we advised. Also, mind-body exercises such as Tai Chi, gentle yoga. These are things that will allow integrating physical activity to social and cognitive exercises. Build more activity into your everyday. So if you know that you can climb a bit of stairs instead of taking an elevator, that might be good. So those are some of the general advices that we gave. And again, you can review those in our write-up. The other thing is like really a cluster of things that we consider it. It's all about your heart and vessels. And we always said that what's good for your heart is good for your brain. So if you think about a cardiologist, an internist will tell you, well, I want your blood pressure to be in the right place. I want your cholesterol to be in the right place. Well, that translates to good heart health and vascular health, but also brain health. So healthy diet, and then smoking. I mean, there was a generation, including my father's generation, who just considered smoking as part of their lifestyle, and it was something that they've done without any hesitation, and unfortunately ended up being really bad news for their health. And I know that some of those who are listening to me now might be those who grew up in that era where smoking was the norm. Unfortunately, we are seeing some recurrence of smoking through vaping in the younger generation. But hopefully we can continue to help people not pick up this habit. It's tough for you on your vessels and your heart and on your brain. Maintaining your healthy weight with balanced diet and exercise, take care of the type of food you eat, reducing inflammation. One thing that we know that stress and inflammation tend to actually allow more damage in your vessels from things such as smoking, from high blood pressure. So in a way, it's a egg and a chicken thing. I mean, which one comes first? But in reality, we can't afford waiting to discover which one comes first. We have to address both. Now, the other thing that I mentioned is hearing and vision, and you can definitely do something about it because, check on those because, it's very easy for you to go for years not knowing that you have some hearing loss. And it shows up in things such as, sitting in the back of the car and not hearing what people are saying in the front, being in a crowd, and all of a sudden you really have to tune into one person at a time. So there's a lot of signals, but checking on it is the easiest thing to do. It's very precise science. I mean, I did check my hearing when I suspected it, and sure enough, I'd had a very high frequency loss, which is, not something I would have noticed, but it's important to protect my brain. Using lenses, protecting your senses from damage, loud noise, ultraviolet light for your eyes. But also, this is the point that we put in terms of use your senses in a way that will enhance your social engagement, right? So there's a pragmatic need for hearing and vision to survive, but also I think it will go even further if you give it the opportunity to enjoy the colors, enjoy the sounds by listening to music and so on. Protecting your brain from damage. So, falls are things that we deal with as we get older, or postural reflexes or reflexes of standing are not as good. So head injury is something we need to prevent because, repeated mild concussions can result in significant damage, and really fall prevention is an important aspect. I did see some of the homes, for example, in Amica, and it's nicely laid out, wide hallways for people to walk without being at risk of stumbling on something to fall. Depression, I can't emphasize this enough. I mean, it's my area of work. I help so many people who have gotten depressed, did not get the right treatment, lingered for years in a state of depression. Well, that damage is something that we need to stop. I mean, the brain has to be protected from the damaging effect of depression. The same with alcohol. And then really building brain resiliency, healthy habits. So in general, really fight aging and injury by building more and more connections to have more reserves. Keeping your mind active. We all know how beautiful it is to be able to engage with a young mind, like what looks in the pictures, grandfathers reading to granddaughter. This is, I mean, finding a way to maintain your activity and solve puzzles, brain games, really do mental workout, if you will. So it's all about increasing connections. Some of the exercises I mentioned earlier come in handy too, because learning how to move in space and engage socially while you're exercising now increases the game quite a bit. For social connections, as you know, are definitely rewarding in all aspects. Now the sleep. So I want to go back to sleep because while we did not have a specific article on sleep, because at the time the Lancet report did not identify it specifically, I'll tell you why. I put it as that they slept on it in a way because they were not sure if the evidence is clear whether it's a cause or effect, meaning that is sleep disturbance an early sign of cognitive change, or is it something that caused cognitive change? So they were not sure about that. But more evidence since the publication of the Lancet report that showed that sleep is indeed a preventable factor for dementia. For example, the Canadian longitudinal study on aging that I mentioned did identify sleep as a factor. More recent systematic reviews, and so the systematic reviews basically when scientists sit together and look at every single published paper, try to organize it, try to understand what is the meaning of the numbers and do analyses on it. So basically those papers have confirmed that sleep is a modifiable factor for dementia. And there's actually an interesting article that came out very recently this year in Nature Communications, a very respected journal, to show that when people sleep, they tend to have a bit of a suctioning mechanism from the vessels. They call it the lymphatic system, where toxins, so the longer you sleep, the longer you may, the deeper you sleep, the more you allow your brain to be actually washed out of chemicals such as amyloid and the toxic effect of it. So I think, my guess is that the next iteration of the Lancet report will include sleep, because now we have very good evidence to support. Now, I wanted to share with you some of the evidence of, what if you actually prescribe lifestyle interventions in a very specific way? Does it make a difference in preventing dementia? So this is something that was done by the Alzheimer's Society. And this is a publication in the Journal of the American Medical Association in 2025. The study, they called it the Pointer study. So in that study from the US, what they did, they allowed people to be informed about lifestyle. And they said, okay, what if we get the groups, like randomly assign them group to do their own thing, like they now know what's the right thing to do. But the other group, we get them to actually follow a very structured approach. Like we will give them specific guidelines and a prescription in a way. And they did see that those who have the structured approach did better. The effect was not tremendous in a way. Like, I mean, I was a bit disappointed. I mean, so definitely they did better, but there's a question whether could we even improve it further. So if you give somebody advice about their exercise, about controlling their vascular factors, about diet, you should do, so now comparing the two, there's about 29% difference, but it's not really tremendous. So we're really looking for a little bit more. And then we actually have been in this field from the Canadian group. We have a study we call the Synergic trial, so synchronizing exercise, remedies, and gait and cognition. It's a trial that was done led by Dr. Manuel Montero Daso. He's a geriatrician, professor at Western. So the first study we did was 175 people with mild cognitive impairments. It's not prevention, it's actually those who already have mild cognitive impairment, 65 to 85, 20 weeks of multimodal intervention. And at the time, we combined different combinations. So you can do exercise plus cognitive exercise plus vitamin D. And we wanted to see what makes a difference. And we did find that aerobic and resistant exercise added to computerized cognitive training that's very well designed actually is quite synergistic, meaning that they enhance each other's effect, both in cognition and gait, speed, so even improve your chance of staying well and not fall. That's tremendous because we know that fall will also affect cognition, as I mentioned earlier. And that was significant at 6 months and at 12 months, so it carried the effect longer. The one surprising thing that vitamin D, despite all the advertising about vitamin D, let's give it to everybody, it didn't really add much value. So I think vitamin D, in my view, is useful only if there's a D deficiency and there's a high risk for bone, bone not being healthy and mineralized. But giving it without that doesn't seem to make a difference. Now, the exciting thing is that the Synergic 2 trial, which is the same study that we're now almost done with, we have already 500 people enrolled. We still have 50 people more, so you're welcome to join the study. What we did, we actually moved it toward a home-based exercise. So basically, if you are in the study, you'll get an individualized coach over 12 months, and they'll give you a home-based exercises, both cognitive and physical exercises. And what's nice about this, that it's one of the largest studies of its kind. It's going to add value to the Pointer study. I remember I told you the Pointer study gave a recipe, but this one adds to it a coaching. Like it's not just do the right thing, because you know that you have to do the right thing, you don't do it. Somebody will give you a recipe, you may do it a little bit more. But if I'm with you throughout the 12 months and support you through this journey, problem solve around the issues that you may run into, I think we're going to do better. So we're looking forward. And again, if you're interested in this study, please reach out. This is the website, because you can get involved if you have mild cognitive change, like somebody told you that your memory change is significant, but it's not affecting your ability to function yet. And you're between the age of 60 and 85, I think is the limit. Now, treating depression. So one thing I mentioned earlier, that depression is a risk for dementia. Well, it does seem to increase the risk of dementia by at least close to 2 times, 1.5 times for Alzheimer's disease, over 2.5 for vascular disease, so vascular dementia. So in a way, there's no secret that depression is something that we could do something about. And we have been very active in treating depression. We all know that depression could respond to maybe talk therapy or counseling, but sometimes it doesn't work. Then you have to go to medications, and sometimes even medications don't work. So I end up usually seeing people who are not better after trying medications and psychotherapy. And we have been working on a very precise way of treating depression, which is going to the areas of the brain that has to do with processing emotions and thinking, and actually change their activity level by using magnetic field. The magnet is very non-invasive, so there's nothing going through except for the magnetic field. It reaches the brain, it activates the brain areas, it changes the firing rate. So we have shown in a very nice meta-analysis by one of my brilliant students who's now doing medical school in Dalhousie, Dr. Fad, that using this particular pattern of simulation tend to improve memory and help people be more in control of their emotions and improve their even walking distance. So this study is continuing. We actually have a study as we speak, doing it at Ontario Shores and Mackenzie Health. So a person who have depression in old age, and basically we define middle age, basically 50 and older, who want to be treated with this. We assess their memory, feeling, walking. We give them intensive course over 5 days of this magnetic simulation I mentioned. And we also measure their mood and gait and cognition after, to be able to tell. Now, what the study is going to involve even looking at brain activity, about pattern of movements in the community, their pattern of movements from physiology of their heart, and so on. So we'll be able to help people, but also learn a lot in terms of what need to happen to improve people's mind, mood, and walking in this case. So I want to get back to the amyloid story to tell you what's happening in that field, because this is in the news. As you know, there's 2 drugs that has been approved in Canada. So just to remind you that amyloid accumulate up to 20 years before the illness shows up, right? There has been a lot of drugs that being designed to remove amyloid, but also to maybe block the formation of amyloid. And the 2 drugs are now on the market in Canada called lecanemab, and which is the Kempi, and the donanemab, which is Kinsula. No, these are approved by the FDA, but they just got approved in Canada. One in October and one actually just now, May 1st. So what does that mean to you? I mean, if you are somebody who is struggling with memory function, you're still doing okay, you're still managing your own affairs, you're still driving, but you do have a reliable change in memory, you may get assessed and they'll tell you have something called mild cognitive impairment. Then we test your blood to make sure that you have, if you have amyloid and you have what looks like Alzheimer. Well, there are centers now, Sunnybrook, the Toronto Memory Program, and other centers as Sparking that can actually treat you. The problems with this, a few. One is that you have to have a proven amyloid story. So, I mean, people have cognitive impairment due to depression, but they don't have amyloid. Well, treat depression there. If somebody carry ApoE gene, there's something called ApoE4. So each one of us will have 2 copies of that gene. ApoE could be a number that's 2, 3, or 4. If you carry the ApoE4, one copy is okay, no copy is okay. But if you carry two of them, then unfortunately you cannot receive this treatment in Canada because it can cause more brain swelling, having those genes. The treatment will remove amyloid from the brain, that's confirmed. What it does when it comes to the illness, it can buy you about 10 months. So still not optimum, but definitely those who are on the active treatment will decline 30% less, right? At this point, it's still given by infusion, so you have to go to a specialized infusion center. The Toronto Maybe program has one, Sunnybrook and other places have one. Cost is a big issue at this point because the Canadian Drug Agency have not recommended funding for it yet. Provinces don't fund it yet. We had some premium insurances that funded it, but otherwise you are looking at $35,000 or so the first year, and then maybe half of that the year after. So it is what it is today. It's the beginning of this field. There's one at least signal of hope that we can actually modify this illness. So now I'm going to shift gears a little bit and tell you a little bit about behavior. So I've shared with you so far the general rules about staying well, and if you develop an illness, a cognitive impairment, how can you go about finding out? What can you do to stop it? But behavior is an aspect that continues to be a core part of this illness, dementia and Alzheimer's disease. And you can see different type of behavior like apathy, depression, aggression, all this happen throughout the journey. And the agitation itself, which is one of the biggest problems that get people really upset and get caregivers upset and burned out, increases as the illness progresses, right? So from mild cases all the way to severe cases. So we have been working with international groups to define this. So we know that a person with agitation is somebody who had this emotional distress. They're moving around, they're pacing, they're looking for something, but they're not doing it for fun. I mean, sometimes if somebody's moving around and just staying active, that's fine. But if they're upset and they're looking for something or fearing that something wrong happening, that's agitation. And so increased movement, and sometimes that result in verbal aggression and physical aggression, and it's very hurtful to the loved ones and family who are trying to help you, to be yelled at or called names or being hit. And the same for care providers in places like Amica, long-term care, hospital system. So if this is a manifestation of 2 weeks or more that's severe enough, not caused by anything else that we can see and correct, like an infection or a medication change, then that's agitation. And it's very difficult to cope with it. I mean, it affects people living with the illness itself. They can get exposed to physical restraint. They tend to decline faster. They can die more due to this symptom. And caregivers definitely get a lot of that negative output, unfortunately. So we are now very clear that if somebody has Alzheimer's disease or dementia, if they develop agitation as a symptom of that illness, they tend to decline much faster. So they basically go toward advanced stages much faster. So twice the risk of progression, but also they tend to die at least 1.5 to 2 times more than those who don't have agitation. And this is not because of medications, by the way. It's just regardless, if you actually control for everything, agitation itself is bad prognostic sign. Now, the other thing that we all have heard about is the use of antipsychotics and how that being criticized, very rightly so, because obviously these drugs are not completely safe. I mean, when you use them, you have to be very aware of the risk involved. So we have been working on regulating the use of medications like antipsychotics for behavioral symptoms of dementia. And we worked on quality statements that are now available from Health Quality Ontario to show that when a person presents with agitation, so we now know that they have dementia of Alzheimer's disease, all of a sudden they get very angry, upset, striking out and yelling at people. Well, let's first understand, like, why is this happening in this particular person? Is there anything that is specific to their environment, to their health? Do they have an infection somewhere? Are they in pain? Are they fearful because they now hallucinate and worry about somebody trying to hurt them? So after you do that, you try to develop a plan that has to be individualized and start by giving non-medication intervention first, because we want to know maybe it's triggered by poor lighting and somebody who's visually impaired and not able to see around. So of course they're going to be fearful in the room, not knowing what's there and what could be coming to harm them. But after that, if you still need to use medication, so this is really the quality statements we had for medication is that, we know that there's inappropriate use, so we need to make sure that the medication we're going to use are first needed, meaning that you know specifically why you're giving it, what is the target. You start low and go slow and make sure that you're not causing major side effects like falls or risk of stroke and death is there too, and we have to take that into account. So we're really working on trying to find a way to reduce the inappropriate use of medication. And myself and Dr. Vazadev from London, we did look at the pattern of use of these medications in long-term care, and unfortunately, we did find that it was continuing to be inappropriate, and a lot of medication are thrown in. Now, people are not doing it out of bad intention. They're trying to help, but we need to help by having a good framework. So we actually worked on such a framework. We actually worked with the colleagues from CAMH, London, Ontario, Calgary, across the country, really, on a study to standardize the care for neuropsychiatric symptoms. So this is a study that will allow us to say, okay, what is the best way to treat this illness and how do you use medication and so on. And we published a lot of this about designing good behavioral intervention to manage vegetation, make sure that it's done properly. And then we also worked on creation of an algorithm for medication so that when we start with medication, we don't just throw random prescription. We know which one has the best evidence, what is the risk involved, how do we monitor for that risk. So this study, just to share with you, it's concluded. It's actually just got accepted for publication. We did it in inpatient unit and hospital, but also in long-term care facilities. And what we learned that organizing ourselves and having a clear algorithm helps us not to overuse medication. So that's something that we're going to continue to work on and increase the way it's done in long-term care facilities and other places. There are also some new drugs so we know what we have today is not enough. It doesn't seem to be adequate. So most of these medications work to some extent, but not fully. So we are studying things such as the cannabinoid, like things like the marijuana, the escitalopram trial that we did that unfortunately did not seem to be successful, but that was important news because people were prescribing escitalopram, assuming it's safe, it's easy to use, it's good. Well, we discovered through very rigorous testing that it's not helpful, but also can increase the risk of falls and arrhythmia of the heart. And then there's some new drugs that are now approved in the States and now coming to Canada, including something called AX05, which I'll tell you a little bit about. So the escitalopram trial is an example of a trial that's funded by National Institute of Health in the States, and we participated in Canada. And we discovered that a drug that was considered benign can be prescribed by anybody that should not be prescribed. So we don't only do studies to bring new drugs, we actually can remove drugs that are harmful. This is the new medication with completely different mechanism. So dextromethorphan is a cough syrup that has been used for years. It turned out to actually have a very good effect on the brain, calm people down, and now it's approved by the FDA and it's coming to Canada. I'm going to be running a study to demonstrate its efficacy and safety. This is the Nabilon study that's active. So anybody who have agitation with Alzheimer's disease can be referred to the study. In fact, one of the Amica sites near our hospital in Pickering have already referred one person and had a very nice involvement in the study and did well. And after the study, we're able to prescribe medication to help continue to be well. And cannabidiol is looking at the CBD component. This is another medication that is coming for agitation. Again, avoids the antipsychotic route, so it has a different mechanism. It enhances one chemical in the brain called acetylcholine. So this study is happening too, and again, people can access it. You can always reach out, and we'll be happy to support people with agitation and their families. The other thing that I was trying to allude to earlier is measurement, like in terms of how can we make sure that we don't wait for agitation to happen, then jump to try to help the person. And by then, the crisis is in place, people can get hurt. So we're working on something called, like the wearable devices, but also using advanced analytics with artificial intelligence to try to see if we can predict agitation before it happens. So in our first analysis of our study showed that we could predict agitation up to 6 minutes before it happens. So that gives us a bit of time to say that so-and-so are going to get agitated in 6 to 10 minutes. Maybe you should make sure whatever is happening in the environment, adjust it, provide them with something that will give them comfort, and maybe music, maybe a snack, and then see if that could prevent it and be prepared. The big news that I mentioned earlier, that when we talked about our organized way to help people with agitation, we now have a huge study funded by a very generous donation by the Slate Family Foundation to actually get us to improve the care of behavioral symptoms of dementia in long-term care using technology as well. So basically, some of the devices that I mentioned, virtual reality, wearable devices, will be implemented to enhance care. And this is our work to support caregivers, because we know that caregivers that are family members or even care providers in long-term care or in homes like the Amer Care Center, these are people who need to be prepared to know how to deal with a crisis or with the lack of interest in care or refusal of care. So what kind of communication tools you have? How do you respond to this? How do you process your own emotions? So we have now a study that's going to finish this year. We created actually scenarios in virtual reality to help people practice and express their emotions and get advice and get trained and increase their competency to, and this is going to be available again within that initiative in long-term care, but also beyond that. So just to recap, I mean, I know that there's a lot to talk about when it comes to these illnesses. I think, maintaining brain health is a lifelong journey. So you can't stop now. You would have wanted to protect your brain from day one. About half of dementia cases can be prevented by addressing interactive factors that I highlighted to you. Lifestyle factors are important in preventing dementia. Several medical and psychiatric illnesses can contribute to the risk of dementia, and we really need to make sure that those are treated, addressed. There's opportunity to improve quality of life, function, and health throughout the journey of cognitive aging. And as you heard from me, that a lot of the research that we do is really an opportunity to receive best quality care while we're trying to find new ways to improve the life of the people that we care about. A lot of funding and support have been received, but really most importantly, families and patients and research teams and organizations, care environments. I mean, I just mentioned earlier how Amica just endorsed the relationship we had, and they did refer people to the study. We went there. I went them on site to do the physical exam to reduce the burden on the person who participated and the spouse, who really appreciated that. But these are the kind of relationships that I really hope that we can continue to foster, like bringing people together. Any questions you have about our studies, these are my emails. Hopefully this will be available to you as well. But I'm also happy to entertain some questions. I know some of them were posted in the chat, but I'll let Melissa kind of lead through that process.
Thank you, Dr. Burhan. Thank you so much for today. I really learned a lot, and I'm really grateful for you putting this together for us here. I've written down a few of the questions as we went. The first one was, is dementia a genetic problem? Is it inherited?
Yeah, excellent question. So dementia, as I mentioned, is a very broad kind of term that can mean anything. Like a person who have head injury will have a dementia due to head injury, or somebody with a stroke. But there is a group of illnesses like Alzheimer's disease, for example, that could have a genetic predisposition. So about 1 to 5% of Alzheimer's cases would be actually inherited. you would know for sure that this family has, unfortunately, the gene that will lead to Alzheimer's disease. But this is the minority of the cases. The majority of the cases will have more of a family tendency to develop it. Like, for example, ApoE4 is a gene that I mentioned earlier. So if you carry ApoE4 variant, 2 copies of it, your risk of developing Alzheimer would be higher. That doesn't mean that you have to develop the illness, right? So just to be clear, there's genes that are deterministic in the sense that if you have that gene, you have a high chance of developing it by a certain percentage, like 50% chance by a certain age. While the majority of the cases is more of a family tendency to be vulnerable. They call it susceptibility, right? So that's kind of the quick answer about the genetic contribution.
Okay, so we have a couple new questions rolling in, but I had a few from earlier on. Somebody was asking, what is vascular dementia?
Yeah, so vascular dementia is really a term that we use to describe a person who might have been doing okay, developed a stroke or small mini strokes that accumulated over time, and those just really took away some of the brain networks that are needed to function. But it's different from Alzheimer's disease because in Alzheimer's disease, the illness is neurodegenerative, meaning it's progressively getting worse because of the accumulation of the proteins that I mentioned earlier, amyloid and tau. In vascular dementia, you could have a big stroke that results in some cognitive impairment to the extent of affecting your function, but you may stay there. Like there'll be no progression unless you have another stroke. Now, this is the simplified version of it. Sometimes, unfortunately, they happen together. So a person will have vascular dementia, and then they start progressing. Then we know that Alzheimer now is part of it. But the short answer that vascular dementia refer to dementia due to stroke or blood vessel disease in the brain.
Somebody was asking, this was earlier on in your presentation, Dr. Burhan, but so some of this was covered, but are there any specific scans that people can undertake to help identify the type or the progression of the illness beyond sort of tests that are on paper?
Yeah, excellent. So today, we're really in the era of precision diagnosis for Alzheimer's disease. So we no longer, the clinical profiling of Alzheimer's disease is basically, as you said, it's a clinical criteria. So a person come to me and say, well, I've noticed that I'm forgetting new things. The family will confirm that it's progressing over time. So I use that clinical criteria to make a diagnosis. But today, if I want to know if this person have a specific form of dementia, such as Alzheimer's disease, then we could actually do a few things. One is a blood test that I mentioned earlier that could tell us, is there likelihood of having amyloid in the brain, Alzheimer's type. We can confirm it further by doing a spinal tap. So we get the fluid from the cerebrospinal fluid, and then we can do the analysis on the chemistry there. But we also can do something called PET scan, which is a picture of the brain after we give a little radioactive material to detect amyloid in the brain. So we can be 100% certain that there is Alzheimer's pathology through a PET scan, for example. We know for sure. So yes, and so that's now there are some other testing important. For example, for Lewy body disease, there are evolving ways of looking at different pathology. But let's say I see somebody today and they said, oh, I had a sudden change in my cognition. I may do a MRI and find out that they had actually a bleeding in the brain, right? So there's different scans for different purposes, and we have to be clear that the clinical picture guide us to say what would be the best test for this person to confirm what they have.
Thank you. So we have a couple of other questions here. I don't know if we'll be able to get to everything, but somebody asked earlier, how is it that hearing or vision can impact our brain, or hearing and vision loss? I apologize.
Yeah, very good. Again, it's one of those things that we maybe didn't take seriously before, but in reality, your input of information to the brain is through your senses, through your hearing and through your vision, right? So if you are in a state of low input because you don't have optimum hearing, well, you disadvantage yourself because then less and less connections are formed in the brain, and your brain actually just fades away, because use it or lose it is a rule when it comes to brain function. It's similar to when you don't use your muscles and they're fading away. So we think that neuroplasticity is important to maintain the integrity of our brain networks, and that comes from hearing and seeing, right? So those are important aspects to consider.
Dr. Burhan, if it's okay with you, there's some excellent questions that are still rolling
Yeah,
in,
no,
but I want to
I'm happy
respect
to stay
people's
on.
time.
Yeah,
Oh, okay, just for a couple of minutes.
yeah, for sure.
I just think, okay, so somebody was asking earlier about, would a Mediterranean diet or an organic diet be something that you would recommend to patients for their brain health?
Yeah, I mean, so this is something that is in those articles that we described
Mhm.
with Amica, that there's some, first of all, I mean, diet in general allow you to maintain a healthy weight, healthy blood pressure. All these things are already good for you, right? Like a healthy diet is already good to control your sense, if you're going to get into obesity, that's already a risk factor. So avoiding that. But also there are some elements in diet, like Mediterranean diet is an example of a diet that has been popular as a good brain health diet because it has good amount of antioxidants, good way of getting the sugars to the blood without spiking up. So they call it the good glycemic index. Then some of them have anti-inflammation component, so reduce inflammation in the brain, antioxidant component. So definitely we have a whole set of advice around diet. In general, green fish, drinking modestly, hydrate yourself. Those are general rules. Avoiding red meat if you can. There is a lot of issues with triglyceride, and don't avoid highly refined sugars and stuff like that. So, but you'll get more advice from a dietitian. I just wanted you to know though that it is a real thing, and we want to maintain a healthy diet.
Okay, I'm just going to do a couple more quick ones because I know you have a
I'm,
practice
I'm
to get to
able to
and
stay
people.
along for another 10 minutes. That's fine. Yeah.
Okay, all right, wonderful. Okay, so now a couple of these questions I don't actually understand, but hopefully you will. Oh, well, I understand this one quite well. If you are concerned about a loved one, they have advanced Alzheimer's, how do you know when it's time to move into a residence that has memory care, be it Amica
Yeah.
or somewhere else?
Yeah. Yeah, I mean, honestly, those decisions are so tough for families because we all have commitment to each other to say, I'll care for you and support you, to basically till the end, right? So it's always that guilt that unfortunately make people hesitant to say it's time, right? Usually, as I advise people to speak to like something like the Alzheimer's Society or a coordinator of a home to say, is this the time? Like, so don't sit with that question, by yourself and keep struggling with it. Speak to somebody about it because my parameters is that if you are unable to have a normal quality of life where you can't sleep well because you're worried about your loved one getting up at night and leave home, you're unable to sleep because they make a lot of noise or come back and wake you up and want to go somewhere. If all of a sudden they're falling and you can't even lift them because now your physical needs are such that you can't do that. So I really think that your well-being as a caregiver, as a family member, is a good metric to say, can I still do it without myself burning? I want to remind everybody that caregivers, especially all spouses of people with Alzheimer's disease, are at 6 times the risk of developing dementia themselves. That's because of the constant drainage on health and the stress that they deal with. So my advice, don't wait too long. Speak to somebody about it as soon as you can because you want to know, is this my limit, right? And you're not letting your loved one down. You did everything you can to get to this point. It's time to actually make sure that you're still available with the resources and the emotional well-being to care and continue to enjoy. The couple that I worked with recently at Amica, it's a perfect example of a very realistic spouse who lives in the same building but able to actually spend time with the loved one, not really burning out every day, and able to recharge when they're not caring for the loved one immediately.
And then thank you so much, Dr. Emmer. There's just a couple of rather technical questions
Yeah, yeah.
that I don't understand, but you will. So there's two here, three actually. So, and maybe you can decide the order here, but how does FMD fit into this picture? Um, uh,
Yeah, so maybe I'll
There's
ask.
a question
So
about
FM,
PET scans and do MRIs always detect TIAs? Those are
yeah, so I'm reading those questions. So FMD, I'm not sure if I know what it stands for, but FTD, I know. is a term like frontotemporal dementia is a form of dementia that affects people relatively younger, and it affects behavior more than memory. So I'm hoping I'm answering the right question here. That's the one. FMD, I'm not sure if I understand the term, but FTD I do, and maybe the person could type to make sure I'm talking about the right term. And then you talked about, is the same PET scan would be diagnosed cancer, and yeah, so PET scan it's really a radioactive or nuclear medicine type of testing, and it can be designed in a way that will detect anything. Like, for example, a cancer may have a marker that a PET scanner could detect specifically, right? In the case of Alzheimer's disease, it's the same technology, but we're using it to detect different chemical in the brain called amyloid. So, and they're difficult to access because actually they are expensive, about $6,000 for the scan, and they're not as available. They're not clinically available at this point, but we do access them through studies, which is why I always encourage people to participate in study, because if it's not at the end of the day, if it's not a good study for you, at least you would have done all these tests for free through the study. So PET scan, amyloid scan is routine practice in our frontal memory program, for example, as part of the study. And then the question about MRI, I think, so one thing about MRI, so magnetic resonance image is a very good, I'll answer the FMD question and soon. So the MRI, just to start with, so magnetic resonance image is a great tool to have a very good picture of the brain structure. And it will allow us to see if there's any damage in the brain that happened previously or change in the structure. So TIA, by definition, which is transient ischemic attack, it's a stroke-like event that is not supposed to be permanent. And it says it happened and passed through. So MRI is an important investigation in that case, because what if the person had a silent stroke before? So we usually look it up and say an MRI was done. I do not see anything left. Then I can be more assured that no damage happened from that transient ischemic attack or TIA, right? So it's a good test for that. And the functional movement disorder. So this is a term that's reserved for illnesses that look so neurological, like a person may have a Parkinson-like manifestation, but then the neurologist who examine them will say, well, it's not consistent. It seems to be, something that is likely driven by psychological need or a change in kind of the mental state of the person. So that will not be under what we call dementia. It's really a different type of illness that we have specialists working on, which is what they call the in the neuropsychiatry of functional neurological disorders. And I have been involved with that in the sense that a neurologist colleague would say, I know this person presenting with this weird syndrome, it doesn't add up. But like when I do a scan and everything is negative, so it must be functional, meaning that it's almost the software of the brain doing it, not the hardware. So there's no damage to the hardware. So I hope that answers some of those questions.
Thank you so much. Oh, there's just one more about caregivers. Since you brought it up, the risk to caregivers. What can caregivers do to assess their level of cognition as a baseline when caring for a person with dementia? And then that will be the last question.
Yeah,
thank you.
Right. Well, it's a good question to end on, because it's really a passion of mine to make sure. By the way, I never seen anybody without a caregiver, just because I know how important this is. A family. I mean, there are some people who choose not to, but I always invite them to have their family on. The caregivers, as you said, they are under constant variable stress when they. Now, caregivers are human beings like all of us. They have biological systems, they have illnesses themselves. We know that they're at high risk because they're constantly dealing with the stress, but also they may neglect their own health and they're not able to maintain the healthy lifestyle that they should. So my suggestion for caregivers, one is first take care of yourself and find a way to access care. So when you go to something like the Alzheimer's Society or any programs available for you, do go and really take advantage of expressing your emotions, cry, find a way to actually have alliances and friendships. And then check if your memory is different. Well, is it different because you're just stressed out at that moment, or is it something that started showing reliable difference? And then you can be assessed by the same clinician who have assessed your loved one to see if you have mild cognitive change. Well, let's diagnose it early. Let's find a way to get you to something that will prevent it from progressing, right? So like anything else, you're entitled to take care of your health. It's not all about the person who have the diagnosis. You are a human being that need to be taken care of as well.
Thank you so much to everyone for listening. Dr. Burhan, thank you for sharing your expertise today. And we will follow up with the group, with the resources, the recording of the presentation. And again, I appreciate your time, everybody, today. Thank you.
Yeah, thank you so much for the invite. Thank you, everyone, for listening.
Goodbye, everybody.